Welcome to the emergency room. We've discussed stable diabetes, but today we are talking about the nightmare scenario, diabetic ketoacidosis, or DKA. This is not just uncontrolled diabetes. It is a life-threatening metabolic crash. It occurs in both dogs and cats and represents the absolute failure of energy metabolism. To understand DKA, you have to understand the perfect storm that causes it. It isn't just a lack of insulin. It is severe insulin deficiency combined with a surge of counter-regulatory hormones, glucagon, cortisol, epinephrine, and growth hormone. Here's what happens inside the patient. Because there is zero insulin to unlock the cells, the body is convinced it is starving to death. In a panic, it switches to plan B, lipolysis. It starts breaking down fat stores rapidly to use free fatty acids for fuel. The liver processes these fats and churns out byproducts called ketone bodies. In small amounts, ketones are fine, but in DKA, they are produced faster than the body can use them. Since ketones are acidic, they quickly overwhelm the body's buffering systems. The result? Metabolic acidosis. The patient's blood pH drops, essentially becoming acidic, while they suffer from severe dehydration and massive electrolyte derangements. Without immediate intensive intervention, this metabolic spiral is fatal.
Because of insulin deficiency, the cells are starving despite high blood sugar. This triggers a counter-regulatory hormone surge. Glucagon, cortisol, and epinephrine flood the system, driving glucose even higher. Desperate for fuel, the body switches to lipolysis, shredding fat into free fatty acids. The liver converts these into ketone bodies like beta-hydroxybutyrate. These are strong acids that overwhelm the body's buffers, causing severe metabolic acidosis. Simultaneously, the kidneys fail. The glucose spill causes osmotic diuresis, dragging water out with it and causing massive dehydration. Finally, beware the electrolyte lie. Acidosis shifts potassium out of cells, so blood levels look normal despite a massive total body deficit. When you start insulin, that potassium rushes back inside, potentially crashing the heart. Also, watch phosphorus. If it drops too low, red blood cells will lyse, causing hemolysis.
DKA rarely happens in a vacuum. It is almost always a 1-2 punch. The first punch, obviously, is the diabetes itself, whether it's a newly diagnosed patient, a poorly regulated one, or an owner who missed insulin doses. But the second punch, the trigger, is what sends them into crisis. These are concurrent illnesses that spike those stress hormones we talked about. The most common triggers are pancreatitis and urinary tract infections. Remember, a diabetic UTI is often silent, so hunt for it. In intact females, always rule out pyometra. It is a massive progesterone and bacterial load that causes severe insulin resistance. In dogs, look for hyperadrenocorticism or Cushing's pushing them over the edge. In cats, the picture is often complicated by hepatic lipidosis or fatty liver. If a diabetic cat stops eating due to stress or nausea, they can develop fatty liver rapidly, creating a dual metabolic disaster.
Diagnosing DKA isn't just about seeing high sugar. It requires proving the metabolic crash. We look for a specific triad: hyperglycemia, ketosis, and acidosis. The blood panel. First, look at the blood. Obviously, the glucose will be high, usually 300 milligrams per deciliter. But the smoking gun is ketones. While urine strips work, measuring serum beta-hydroxybutyrate is the gold standard for accuracy. Next, check the blood gas. You are looking for metabolic acidosis, a low pH and low bicarbonate. Finally, check those electrolytes, K, Na, Phos, immediately, because they will dictate your fluid therapy. In the urine, we expect to see glucosuria and ketonuria. Always send a urine culture. Abdominal ultrasound. Look for pancreatitis or pyometra. Spec CPL, FPL, to confirm pancreatic inflammation.
DKA isn't a race, it's chess. You can't fix everything at once. Treating DKA is an exercise in patience and precision. You cannot fix everything at once. Treating DKA requires a strict order of operations. 1. Fluids, dehydration and shock. 2. Electrolytes, potassium and Phos. 3. Insulin, glucose and ketones. 4. Underlying disease. Fluid therapy, the first line. Fluids come first. Before you even touch the insulin bottle, you must restore perfusion. Fluids dilute the glucose and ketones and wake up the kidneys. The choice. We typically use 0.9% NaCl or balanced crystalloids like plasmolite A. The shock dose. If they are in shock, give a bolus immediately. Dogs, 20 to 30 milliliters per kilogram. Cats, 10 to 15 milliliters per kilogram. And reassess. You want a pulse and a blood pressure before you proceed.
Electrolytes, the golden rule. Never start insulin until potassium is agreed about 3.5 milligwigglons per liter. Insulin drives potassium into cells. If you start it while levels are low or even normal, masking a total body deficit, you will cause fatal hypokalemia. Supplement fluids immediately once urine is flowing. Also, watch phosphorus. If it drops less than 2 milligrams per deciliter, supplement it to prevent hemolysis. Start pets on a regular insulin CRI only after 1 to 2 hours of fluids. Drop glucose slowly, 50 to 75 milligrams per deciliter per hour. When blood sugar hits 250 milligrams per deciliter, do not stop insulin. Instead, add dextrose to the fluids. This prevents hypoglycemia while you keep the insulin running to burn off the remaining ketones. Treating the driver. Finally, while the CRI is running, you must aggressively treat the underlying causes.
Treating DKA is a tightrope walk. Often the complications come not from the disease, but from the treatment itself. The most common complication is hypokalemia. As we drive glucose into the cells, potassium follows. If you aren't supplementing aggressively, you risk respiratory muscle paralysis and arrhythmias. Then there is hypophosphatemia. If phosphorus drops too low, less than 1.5 milligrams per deciliter, red blood cells lose their structural integrity and burst. This leads to hemolysis, causing severe anemia in an already critical patient. We also worry about hypoglycemia from overaggressive insulin dosing, but the silent killer is cerebral edema. If you drop the blood glucose too fast, the osmotic shift pulls water into the brain cells. This is rare in vet med compared to humans, but it is usually fatal. Finally, watch out for acute kidney injury, or AKI, if perfusion wasn't restored quickly enough, and aspiration pneumonia. These patients are often vomiting and too weak to protect their airway.
The best way to treat DKA is to prevent it. This puts the power in the hands of the pet parent. We teach owners 3 non-negotiables. Consistency. Never skip an insulin dose and store the bottle properly. Monitoring. Watch the intake. If the polys, excessive drinking and urinating, return, the diabetes is unregulated. Home testing. We encourage owners to keep urine ketone strips or a blood ketone meter at home. If the pet looks off, a quick dip of the stick can detect ketones days before the crash. We give owners a specific red alert list. If a diabetic pet stops eating or starts vomiting, that is an emergency. Do not wait. In a diabetic, anorexia is DKA until proven otherwise. Other signs: profound lethargy, collapse, or that distinct, sweet, fruity smell on the breath. If you see high ketones at home or the pet won't eat, go to the hospital immediately.